Okay, welcome everybody to a very wet and rainy November Health in Hackney. I've got apologies from Councillor Samatar. I am joined here in the chamber by the following councillors: Councillor August Canley, Councillor Patrick and Cllr Baffour. We're joined online by Councillor Adebayo. I have had apologies from the following: Dr. Stephanie Coughlin, Dr. Husbands, Dr. Brown, Caroline Miller, Janet Macmillan, and also welcome to Andrew Trathen from Public Health, who's standing in for Sandra Husbands. Can I also take the opportunity to welcome Louise Ashley, the new Chief Executive of the Homerton and the leader of our place-based system. Just very quickly, in terms of matters of housekeeping, this is obviously a hybrid meeting. We are being live streamed. Members of the press sometimes watch it. Please, can everybody keep your microphones on mute unless you're speaking? Please don't make comments in the chat because I won't be monitoring that. Please keep your cameras on where you can. Please raise a hand if you would like to contribute. Declarations of interest, colleagues? I haven't been notified of any. So with that, I'll then move on to the first substantive item, which we've allotted half an hour for, which is to welcome Louise Ashley to get an update on where we are at the Homerton and also where we are in terms of the Hackney place-based partnership. And some of the areas that we've asked Louise to cover were how she sees her role as a place-based leader, how Hackney's voice as a place can be heard in the wider system, about the elective recovery at the Homerton, how work is going both with the provider collaborative and with St Leonards. And also, we understand work is currently ongoing in terms of the scheme of delegation, in terms of what will be handed down both financially and in terms of powers from the ICS. But an update there, and something I've flagged with Louise, and I think we'll carry on flagging with Zena and Henry at an ICS level as well, is to get a clear understanding of transparency in terms of money flows coming to Hackney pre-ICS and after, and also the other boroughs, just so we understand if there's been any change there. So with that, Louise, could I maybe ask you to speak for 10 or 15 minutes, and then I'll open, or less, and then I'll open up for questions.
Yes, of course. Thank you very much, Councillor Hayhurst. I'm glad to say that Breda she's got away from what she was doing and she's been able to join us. So I am about 5 weeks in, so please forgive me if I don't have all the details, but I know Breda will step in if needed. So it's really good to be here. I'm Louise Ashley, and as you said, I'm the new Chief Exec of Homerton Healthcare, and also very excited to be place-based leader for City and Hackney. I thought maybe just briefly about me. I'm a nurse, general nurse, paediatric nurse, health visitor, and that's my kind of clinical background. I then moved into being a chief nurse across London for many, many years, different places. And then for the last 4 years, I've been a chief exec in North Kent and South East London at Dartford and Gravesham Trust, and also we didn't call them place-based leaders, we called them SROs for place, for down in Dartford as well. So, and I'm not new to the Homerton. It's a coming home for me, which is really lovely. I was a paediatric nurse at the Homerton. I'm not going to talk in years because then that just gets a bit depressing with age and stuff. But it was a long time ago. I was a paediatric nurse there and had the privilege of setting up paediatric services at the Homerton, so Starlight Children's Unit. So as you'll know, that was many moons ago. And then I came back again about 10 years ago to do a director role as well. And it's really great to be back, and what I would say, the sort of vibrancy and the enthusiasm, not just of the Homerton, but of the whole place of City and Hackney has just got better in those years that I've been away, which is really exciting. I took this role because I was really interested in the combined role with the place-based leader role. And I certainly haven't been disappointed. There's been a lot to get my head around in the last few weeks, but what has been really clear to me in my sort of initial observations is that the groundwork that's gone on with integrating health and social care over the last decades, actually, has put City and Hackney in a really, really good place. And whilst in health, all the buzzwords around integration and integrated care systems, etc., are there, actually what's clear is in City and Hackney, we're way ahead. And some really, really exciting work going on. I think for me, my initial priorities have been to try and get to see and know people, and there's so many people to get to see and know, and obviously I'm really keen that I get out to meet patients and residents and really get a feel for what people want, not just from Homerton Healthcare, but from the whole system. And that's going to take me a little while to do that, as you can imagine. I think the way in which people are integrated in their thinking across health and social care is really unique in City and Hackney. And my ambition, and I hope you share this, is that that we really will continue to really lead the way with the integration agenda. I think that lots of people are struggling with it, and I'll come on to this in a moment, but I think rather than everyone sort of sit back and look at City and Hackney and say, oh yeah, well, they're doing, you know, quite good things, but we're not quite sure what. I actually think we should be really bold. And I think our sort of future continued funding or good funding and the way in which we work is actually dependent on us really raising our game, putting a spotlight on what we're doing, and being the City and Hackney model of integration that people look to across not just London, but across the country. And I don't think I'm being over ambitious in thinking like that. And I certainly can't take the credit for the fact that I think we can really move to that place. The support from everyone really has been extraordinary, and you know, the fact that Cllr Kennedy shares the chair of the Health and Care Partnership Board just shows really that you know, the sort of engagement, and I've never had that before. I've never had the opportunity to have that level of engagement. And of course, Mayor Glanville is on the Integrated Care Board. So City and Hackney are really, as I say, very much front and centre. That's the sort of my positive observations. I have, however, noticed that when I'm at sort of northeast London meetings, quite often City and Hackney isn't mentioned. We can be talking about various health issues or health and social care issues, and they've had very little mention. Now that's usually because there's such big issues to discuss around poor performance and problems across the rest of northeast London, that people, I think, tend to just kind of think, oh, well, City and Hackney are kind of okay, they'll get on with it. So I've been doing a lot of putting my hand up at virtual meetings and face-to-face meetings and saying, well, actually, what we're doing is ... and what about City and Hackney, and what about Homerton Healthcare? And I think I've got to the stage now where I do notice that meetings that people are sort of talking, and then they'll see me and say, oh, and of course, City and Hackney. So I'm hoping it's beginning to work. As far as the whole system then, let's talk about that. I think the risk is always there, isn't it? When you have such a large kind of beast that is Barts healthcare. And I think that's always been a nervousness. That was a nervousness when I was here decades ago, that Homerton Healthcare, for example, wouldn't be able to survive on its own. I have a really good relationship with Shane DeGaris, the group chief exec. I've known Shane for many, many years, and we're working really closely together. And my view is that a lot of the success of this integrated working is about relationships. And I know Matthew as a trainer as well from BHRUT, and again, the three of us working really closely together, I think is really helpful. I know there's concerns about the money and the question around the kind of standing financial instructions, the kind of power to act, where's the money going to go? And the system is currently working, as you know, on a sort of financial strategy and looking at that. I don't think it's going to move quickly, is the impression I get, and we're certainly very engaged in the discussions. I think we're all pushing, and I'm particularly pushing with Sir John Geeve around, we are not going to level down across City and Hackney. There is no point in North East London kind of taking money out of somewhere like City and Hackney when it is very successful. And this goes back really to my point of us becoming a real beacon of integrated care, and kind of really pushing the fact that actually we are doing this really good stuff and people can learn from us, and therefore removing resource to try and level it up somewhere else that hasn't had the investment, for example, in primary care, or even the models of primary care that have been developed here, would not be the way to go. It's just not the right thing to do. And actually, I think that's fallen on pretty positive ears, actually. I have a good relationship with Zena, the chief exec of the ICB, and with Marie, and certainly the impression I get is that nobody wants to do that. The way the finances will work in the future is that you'll have heard probably that there may be a return to a different sort of funding for health. So something called payment by results, where basically we get paid for what we do. Whereas at the moment, for the last couple of years, we've been working on what's called block contracts. So we get paid for all of the work that we do. I think that probably will come in. So the ICB will continue to pay trusts to feed down the sort of revenue into trusts to provide healthcare. There will be some monies that go to place-based committees, is what they're saying at the moment, for development work and various other work. That's still very unclear. And there will be some kind of transformation monies as well, that we will need to kind of be in there at that table and making sure we get that. But at the moment, there's no appetite to devolve all of the commissioning and all of the money down to place-based. And whilst that sounds quite an attractive option to maybe do that, and where I was in Kent, we were sort of moving towards that, actually, I think at the moment it will distract us from some of the development work that we need to do in the neighbourhoods. So we need to make sure we get our fair slice of whatever cake's being cut at ICB level, but actually we also don't want to have lots of work kind of thrown down from the ICB without the resources to deal with it. So I want to be really clear before any money comes over that we're getting a fair part of that. And I'm happy to answer any more questions on that. And I know that Rob, who's our new Chief Finance Officer, would also be more than happy to come if people want to have further conversations, more in-depth conversations about the money. So I think as I say, I sort of feel very positive about those relationships at system level, if not a little cautious. How's Homerton doing? I know that was some of the questions, and obviously we have I have a few sleepless nights over a few things, and so I'll share them with you, which might be helpful. One is, of course, the elective waiting lists, which I know you've raised, and our waiting lists are larger than before COVID. That's for many reasons. As you know, in the NHS, we stopped most of the elective work over the COVID period. We have about 25,000 patients on our waiting list now. Prior to COVID, we had about 19,000, so there's about a 6,000 increase. I mean, some of that's to do with various coding things and stuff, but you'll know about the 18-week target. That was the target that we were meeting before COVID. We now have approximately 4,500 people waiting longer than 18 weeks, and that hangs very heavily on our minds, and our clinicians worry a lot about that. That's their patients. They're very frustrated. They want to be able to treat them. They don't want them waiting. We do really, really well as far as in North East London. So we don't have any patients waiting the 104 weeks, as they call it, 2 years, I prefer to call it, just to be really clear. We don't have any patients waiting that long, or the 78 weeks, which is something you'll hear about in health, whereas all of our other North East London hospitals do. But we do have patients who have waited a year for treatment, and it's not good enough. And we all know that. Some of these patients are sitting waiting for, to have their knees replaced. They can't go out, they can't live their lives as they want to. And we are working through as quickly as possible in a prioritised system to get these patients seen. And we're working through that really well, actually. And in fact, we are one of the best in London at working through this. All that said, there's still 72 patients who have waited a year. And it's certainly not something that we are proud of.
Louise, can I just, sorry to interrupt you, because we've got about 10 or so 13 minutes left, and I do want to.
Oh, I'm sorry. I'll be quiet.
It's all right. Is it okay if I just ask you to pause there?
Yeah, please do.
And then I'll ask a question, then I'll bring in any members that do.
Yeah, no, happy to. Sorry.
On the funding issue as to where we are at, I appreciate the Acute Trust may get funded directly from ICS level, but the remainder of the money, so historically, roughly, City and Hackney CCG, I think, had about a budget of about £500 million, roughly speaking, I think roughly around 250 to 280 would have gone to the Homerton as a directly commissioned. My figures might be slightly out. The rest of that would have been stayed at place, save for about 10 to 15% that would have gone up to STP level for commissioning of joint specialist services, for example, cancer specialists, etc., but the remainder of the money and decision making in relation to that would have stayed at place. So I'm just trying to understand, leaving aside the acutes being directly commissioned under the new structure, the bulk of that money that was previously at place level, City and Hackney, are you now saying that the mood is that is going to be, the bulk of that money is going to remain at ICS level and not come down to place?
No. What they've done with that money is some of that money will come down to place. This is the bit that's just not yet been clarified for the coming year. So some of it will come down to place. There has been a top slice of that money across North East London for, transformation, but really for any kind of developments that will then be allocated out to areas. And that's the bit that when I was saying about our slice of the cake, that's the bit that we're negotiating at the moment. So I don't have any clear figures of exactly what's going to come down to place and what's not, but what we have been told is that there won't be a reduction in City and Hackney, but some of that transformation money may be prioritised to areas that have not developed as well as City and Hackney.
No, I understand that. I mean, do you have in front of you that sort of granularity of data about, say, pre-COVID levels, the City and Hackney budget was X, roughly speaking. And so we appreciate you've got to take out the amount that will directly go to the acutes, but therefore we would roughly expect to see, roughly speaking, this amount. I appreciate there's a bit of top slicing here, but are you looking at it through that prism of trying to protect Hackney's interest, as it were?
Yeah, but I don't have those figures in front of me now. I can, what I can do though is get those pulled together for you, so that perhaps in a report that's clearer around when we know a little bit more about that.
Right. I mean, it's something we'll raise with Zena as well. I think from our perspective as well, I think there needs to be absolute transparency at a local sort of accountability level.
Yeah.
Is that if there are money flows that are being sort of under a demographic weighting, Hackney had X previously, but money is essentially being diverted off to other areas. That can't just be done essentially at an ICS level with no level of accountability or scrutiny or knowledge. We need to, I feel quite strongly that there needs to be very clear transparency on that. And I appreciate there are other outer more London areas about they've got an older population. I appreciate those sort of counterbalancing arguments, but I think I feel strongly that there needs to be transparency over exactly what is happening to the money flows.
I agree with you, and I will get you more accurate figures as I have them. Apologies, I don't have them.
No, I wouldn't expect you necessarily to, but I think it's just something as this takes shape that I think we absolutely just need to be.
Yeah, I agree.
All on top. And other members for Councillor Patrick.
Welcome back to Hackney, Louise. I just wondered about the relationship with Barts and the Homerton not having a seat on the ICB board, and how you're working with Barts. There's always been tension, should I say, between the Homerton and Barts. Barts being so big and the Homerton being quite small in comparison. So I just wondered how it's all working out. And you seem to be, from what you're saying, fighting Hackney's corner, but I'd be interested in your thoughts and how you see it working, and how we're going to make sure you've talked a bit about it, how we're going to protect Hackney and the Homerton and the services that you provide to pretty vulnerable people.
Shall I take that? Yes.
Please, Louise.
Yeah, thanks very much, and thanks for your welcome back. So I think we protect ourselves by being really brilliant in our difference. Barts is very different to us, and we are miles ahead with the way in which we integrate health and social care and the development of neighbourhoods. And I think, as I say, I work closely with Shane DeGaris, who's the new chief exec. He has a lot on his plate and has no interest in consuming the Homerton. I think there's a lot of little green monsters wandering around, quite jealous of what we have in City and Hackney, but certainly at the moment there is not those plans. I think we should, this is about patients and the population, isn't it? And we need to get the best deal for our residents of City and Hackney, and we will do that by having really good relationships with Barts and with the specialist services there. Homerton Healthcare, for example, can't provide and shouldn't provide some of the tertiary specialist services, but Barts do that really well. So we don't want our residents to be picking up on bad relationships between their healthcare providers. So I think my role is to actually build really strong relationships with Barts through Shane and through his chief execs. And in that way, I think that's how we will get the best care.
Thanks. I mean, just to building on that point, and I'll bring another councillor. I mean, obviously there's something called the Provider Collaborative, which for those that don't, those members who sort of don't know what that is, that's a requirement under sort of the new legislation for different trusts to work together to provide services. So essentially it would be the Barts and BHRUT, Barking, Redbridge, Havering to work together with the Homerton, and that may be looking, for example, at all specialist services for X go to X hospital and other services go to another hospital. Louise, can you give us any update on where discussions are at in terms of the provider collaborative as far as it would affect the Homerton?
Yep, I can. So I'm Deputy Chair of the Acute Provider Collaborative, and Shane's the chair of that. That then feeds, there's a lot of groups, that then feeds into the Population Health and Care Committee, which feeds into the ICB. And I'm the representative on the Population Health and Care Committee. So the Provider Collaborative currently has lots of different work streams, basically around children, maternity, planned care, emergency care, and they all feed into the Provider Collaborative Board. And that's really to work on things across the system, so things like elective care or emergency care, and make sure that as Acute Trust, we're all kind of working together. To be honest, a lot of that is around the other acute trusts in North East London. So things like ambulance waits and A&E performance and stuff. As you know, Homerton is kind of top in the country for, certainly in London, for a lot of that stuff, and the rest of North East London's at the bottom. So, you know, we support that, and I attend those, and again, it's about good relationships, isn't it? You mentioned actually that we don't have a seat on the ICB. Obviously the mayor sits on that, which is really brilliant. And Shane represents acute providers across the system. So, and that includes us. So Shane DeGaris isn't on the ICB as the Barts chief exec representing them. He is representing acute care across the system. And he does that really well, actually. So we are well represented.
And does John Geeve also chair the Acute Provider Collaborative Board, if I've got that right?
He does, yes, yeah. He does indeed, yeah.
Right. Councillor Goldberg. Sorry, Louise, just hang on my microphone. Here we are.
Yeah, hi. Sorry, Cllr Goldberg. You mentioned before about the A&E performance and the ambulance wait time in the Homerton that is far better than other hospitals. I volunteer for an ambulance organisation, and I can tell you that is true. That is the case. The ambulance wait times is very minimal minutes, maximum 10, 15 minutes on it, which is fantastic. And the performance in A&E is amazing. My question to you is, on the wait list of 25,000 people for elective surgeries, what % of those are classified as urgent life-saving treatments, surgeries, sorry?
Yeah, so they've divided up into 4 categories of urgents, and I couldn't tell you how many are in P1, 2, 3 and 4, but the way we work through it is that all the patients starting with P1s, which are kind of life-threatening procedures that are needed, get completed first of all. So they have the minimum waits, and then unfortunately, if you have something where you are, it's not limiting your life in any way, then you wait much longer. So that's the way the waiting lists work. I can get it broken down into the different areas for the committee if you'd like that.
Thank you.
Thank you. And Councillor Adams?
Yes, thank you, Louise. I don't know if you've covered this one before. In Hackney, we have 7 neighborhoods or 8, I don't know. So, but you know, I've attended some of their meetings, and most of the participants kind of really think that they can make a difference, and they have different priorities. So I'm just wondering, is there any resources, you know, attached to those neighborhoods for them to feel like, you know, they've been empowered to actualize their priorities? And my second question is on St Leonards. So I don't know if you have any updates on the development or not.
I think someone else might have that's someone else
could. I couldn't hear your first question. I'm sorry about that. I could hear the question about St Leonards.
Louise, the first question was, can I just ask could everyone else just let me just see if I can mute himself. Ah, there you go. Fine. Thank you. Louise, the first question was on neighbourhoods and them being able to achieve their different priorities and whether they have the resources to be able to do it as neighbourhoods and achieve that. And the second was on the development of the St Leonards site and any update there.
Yeah, thanks. Great questions. The neighbourhoods, so 8 neighbourhoods aligned to the primary care networks as well. And we do have development funding to support them doing their work. There's never enough money to do what we want to do. But we are looking at potentially setting up a way that people will be able to, and perhaps bringing in some of the universities and some of the academic institutions to be able to work alongside the neighbourhoods to be able to really support the work they want to do. And that is definitely the way to go. Each neighbourhood in City and Hackney has different health needs, and there are some that cover the whole of City and Hackney and all the neighbourhoods, but we want to be able to make sure each neighbourhood can do things that are specific for their population, which is what it's all about, isn't it, really? Secondly, St Leonards, gosh. So as you know, I think we have been offered or have the ability to take over the St Leonards site. So it currently sits with NHS Property Services, and there is a way that that can be transferred over to Homerton Healthcare. We're currently going through the sort of very many assessments that need to be done to check that we can do that. If we just took over St Leonards, there is no money coming, or certainly not enough money coming with it to support it being developed and kept. And that is no good to anybody, because we do not want to take over a building and then find that it's running into the ground. So what we're looking at, there's other assessments as well being done of land values and whether potentially, you know, there's any, so as you'll know, some older hospitals are taken over and some of the land is sold in order to pay to develop other parts of the hospital. We're looking at all of that. It's a building and an institution that we really would love to take over and develop and for it to be continue to be a thriving part of the community. But we've got to get that right, and it takes time to do those assessments. And I know that's frustrating, and you want me just to say, oh yeah, we'll take it on and we'll do it up. Believe me, if I had the capital money available to me, I would do that tomorrow. But we don't. Is it, to be frank, and I don't want to take it on and find that we do a worse job than is being done at the moment. But I will keep you updated on the progress of those assessments.
Thank you, Louise. I'm going to draw this item to a close. We've just gone over time. Yes, if you could please just keep us updated. We appreciate that you obviously need to do those assessments first before you can feed back to us on what the conclusions are. So yes, if you can at the appropriate point update on St Leonards, and I think maybe certainly pre the next NEL Just Health meeting with Zena, 15th of December. I think if either you or maybe Nina could possibly just give us some idea of the sort of what the budget was for City and Hackney pre, say in 2019, say pre-COVID, in the STP period, and just so we can ask Zena and Henry for the same sort of thing across the other boroughs, just so we can sort of get some sort of grip of understanding about what's going on here. I can see Nina nodding. Thanks for your work, Louise, and thanks for coming. Please don't. We often say please don't feel the need to stay now. We're going to go on to other items. We appreciate you're very busy. Thank you very much for coming.
Thank you very much for inviting me, and I look forward to working with you all.
Thank you.
Take care. Bye now.
I'm now going to move on to our second item, which is to do with dentistry. It's an area I think historically we've probably neglected on this commission. It seems an appropriate point to look at it because, as I understand it, powers for commissioning are due to be devolved down to a ICS level. We've got a number of speakers I think what I will do is I will introduce them as I go along rather than do a list now. And the rough aim is maybe to leave in total for those speakers, maybe to speak for about 5 minutes each, and then to open it up for maybe a panel discussion for the remainder of the time. So members, please hold your questions if you can until that discussion point. And something that we've obviously got an eye on is whether at this juncture, with the commissioning coming down to an ICS level, whether it's something we can make any specific recommendations on to suggest any matters, having heard everything today. So first of all, can I welcome Cllr Kennedy, who's the council member in charge, cabinet member in charge of adult social care and health and many other things in Hackney. And also, I'm grateful to be joined by Andrew Trathen, who is a public health consultant in City and Hackney, who's kindly agreed to stand in for Dr. Husbands, who's not very well. And I understand maybe between the two of you can maybe just give us an overview of the dentistry landscape in Hackney and from a public health perspective. So I don't know, Andrew, do you want to kick off, or was Cllr planning to say a few words first?
I think perhaps Cllr Kennedy was going to initiate.
Fine. Cllr Kennedy first, and then over to Andrew. Thank you.
Thank you, Chair. Just to give you a sort of a feel of where this came from in terms of concern. So during the pandemic, I had 2 or 3 quite urgent inquiries about dental care that was, at that emergency stage because of the various COVID precautions. Individuals in actual really quite severe pain. Similar cases documented across the country. Coming out of it, it felt like things had settled down as we came out of the second wave of COVID, but then again, a couple of backbench councillors raising concerns, one based on a long conversation with a recently retired dentist, one based on personal experience, and then anecdotally, some experiences from residents coming up as well. So Steph Coughlin, the clinical lead for City and Hackney, and myself met with Tam, who you've got here tonight, and Reja Manbajood, who's a practicing dentist, who you've got here tonight as well. I'll just give my quick political headlines. I'll let Andrew fill in some of the details. It seems a very rum deal at the moment about what goes on and the whole setup. It basically seems to be that the NHS work provided by, you've got 86 dentists working in City and Hackney across 34 different practices, but they're working on a 2006 contract fundamentally, which is based on base level data derived from 2003/4 treatment levels across City and Hackney. In situations like this, I tend to go and look at, what does the representative body say as far as these practitioners are concerned. And the British Dental Association says it's not acceptable. It regards it as tinkering around the edges. And despite not wanting to do it, it's saying to all its practitioners, you basically have to go out there and do some private work in order to be able to afford to do the NHS work. And when the professional body is recommending that, and the base level data and contract are so old and outdated, fundamentally something is broken. That's what we were being told by our fellow councillors and residents who were speaking to them. I think I'll leave it there. I'll let Andrew fill in a bit more of the data, and then actually Tam and Reja are very eloquent about laying out what the challenges are. Thank you.
Thanks, Councillor Kennedy. Andrew?
Yes, thanks. As has been said, I'm standing in for others today, so apologies if there are elements of the data that aren't at my fingertips. But I am coming at this from actually slightly unusual position because I am a dentist myself, although I haven't practiced for some years now. So I do have experience of providing care under this very challenging contract. So I'll quickly run through the paper that Stephanie Coughlin provided and just try and just add a bit more depth to it before moving on to some of just a quick headline view of the public health situation and what we're trying to achieve in the public health team. Stephanie talks about this contract that has been instantiated since 2006 and to help to try and understand what core problem with this contract is. Prior to 2006, the treatment was paid per item. So if a dentist did 3 fillings, they'd get paid for 3 fillings. For the most part, people were able to set up a dental practice anywhere they wished and just get going and start delivering care and get paid for it. That does create commissioning issues. So to exert a little bit more control over that, the new contract was put in place in 2006, and it moved away from fee per item to a banded system. So that had some benefits for patients. It was very simplified. Patients would pay one of 3 fees, either band 1, band 2, band 3. So band 1 basically is a checkup, band 2 some fillings, band 3 something made in a laboratory like a denture or a bridge. So that meant that a patient could predict very accurately what they would be paying, which has removed a big element of fear for people. The difficulty is that was mirrored for what the dentists were remunerated. So that creates a slightly perverse incentive. If a patient comes in needing 1 filling, the dentist would accrue 3 UDAs towards their target for that. But if a patient came in needing 10 fillings and 2 root canal treatments, a huge amount of work, they would still only accrue 3 UDAs. Now that has the potential for building in a very serious inequality, because the patients with the greatest need have the greatest financial disincentive to be treated. Now, in principle, that was compensated for through swings and roundabouts was the idea, and commissioning with appropriately weighted UDA values was the ideal, but that's extremely challenging, and I'm sure the commissioners have had a very difficult time the last couple of decades trying to make that work. A series of pilots have been running for some years now to try and identify a better system, or that has been going for a very long time. But just recently, as in around about now, I think, some small adjustments are being made to that band system. So that second band, which created many problems, is being broken down into 3 different parts, which can slightly better capture the actual work that's being done by the dentist. And I think that's what the that's what the BDA are referring to when they talk about tinkering around the edges. That is a welcome change and it's helpful, but it's fundamentally not altering this very old and inadequate contract. Stephanie also mentions about business rates. So if you're NHS, you get a reduction on your business rates proportionally. She talks briefly about public health reports. I'll go into that in a moment, but essentially things that don't look great for us locally. Oral health is poor for adults and children. She mentions periodontal disease, that's gum disease, and that's a condition that requires long-term commitment between a patient and a dentist. It's not something that is fixed in a single visit. So that creates a long-term chronic burden of disease for our population. So I think that covers most of what Steph wanted to say. But well, aside from the fact that COVID's clearly had a devastating impact on creating a huge backlog, just because so few appointments could be conducted. I'll go on to that shortly. There are a couple of other notes to this, just identifying the contracts that we do have in place locally. And I think the local dental committee has made some observations, some of which I've already said. But just to say that they say 90% of dentists nationally can't take on new patients. There's only a handful locally who are at the moment. There is a staffing shortage at the moment, making it very difficult, even when there's a willingness to take up a contract and to meet the need. Finding the staff to do it's very difficult. And in terms of future priorities, prevention work, which public health will be working hard on that, the needs of children. In particular, one of my concerns is about children going under general anaesthetic to have their teeth removed. There's no such thing as a minor general anaesthetic, in my view. And for something which is entirely preventable, we need to be seeing as few children in hospital as possible to have their teeth removed. Going briefly to the public health overview, my colleagues pulled together a report here which gives a bit of detail of what our oral health needs assessment found this year. We publish that at the beginning of the year. I won't repeat what's in the paper already, but the broad headlines, well, perhaps just a little bit of information is helpful. There's a rolling dental epidemiology program that runs nationally. Every year, a different part of the population is assessed, and that's our best source of information to understand what's happening with dental health locally. So every few years, we get a snapshot of a particular group. She mentions 5-year-old children, and for children, for adults, broadly speaking, the picture has been from 2015 to 2017, there was a slight improvement, and then things have deteriorated since. And we'll see what the picture, and that takes us up to 2019. We'll see what the picture emerges in the coming years, but it will be difficult to interpret data that comes through now because of COVID and because of the impacts it has. But there's no doubt that it's going to have had a seriously detrimental effect on all aspects of oral health. There's some points about access to care. Access dropped, we were around 40% for children, which dropped about 14% during the pandemic, which is really devastating. You know, I'd hope that would go back up, and hopefully it will recover to close to the pre-pandemic levels, but we shall see, because there's just such a backlog now. And these things do tend to have a domino effect. If things are not followed, if things are not monitored and followed up promptly, it creates more dental emergencies, which creates more strain on the system. It's more difficult to treat, and it's going to take some time to try to reverse that at the population level. Final point is that we do commission a prevention service. Kent Community, NHS Community Trust provides fluoride application for children, which is a really good, well-established, very strong evidence-based intervention. We also take the opportunity when we provide that fluoride application to do a very cursory examination of the children's mouths. It's not like you can do a good examination for a child who might not be entirely cooperative in a nursery, but you can spot if they may perhaps be a candidate for a general anaesthetic and might need multiple extractions. Another key element of that service is to provide training to carers for children, and in care settings as well, help carers deliver the nice quality standards, and make sure that in schools, nurseries, the staff are capable of doing things like supervised brushing, running events to help educate parents, and so on. We've noted a particular issue among the Orthodox Jewish community, who have somewhat higher rates of tooth decay than in other groups around the borough. And we've allowed our service to subcontract an organisation with a specific insight for that community, so they can hopefully deliver something that's more suitable. So hopefully that's given some useful context. I'm happy to answer any questions that I'm able to.
Thank you very much, Andrew. We'll come back for questions shortly. Can I next then welcome Tam Bekele, who is represents the local dentists on the LDC, which I presume stands for the Local Dentistry Commission or Committee. Tam, welcome. Could you please give us maybe in 5 or 6 minutes, could you maybe just give us your overview as to what you think some of the strategic and structural issues are locally? You're on mute there. Let me just. Oh, Tam, you just unmute yourself. Oh, that's better.
Can you hear me now? Sorry, Chair. Yeah, thank you very much. Thank you for the invite. And I think most of what I was going to say has been taken up by Andrew. So what I'll do is I'm going to concentrate on just a small part of the contract, and it is impact on both patients and with also dental practitioners. The issue with regard to access is very important. I think that is at the moment that is becoming quite uncontrollable, which is actually something to do with when the contract was initially determined. The contract was determined in 2000. The contract value or the contract was determined in 2004 and 5, and that was implemented in 2006. At that time, dental uptake in City and Hackney was low, and the contract was based on that, but no needs assessment has been done. As a result of that, throughout the last how many years, the dental budget was not enough because it was based on needs assessment. It is not based on needs assessment. It was based on the earning, the previous year earning of a dental practitioners, and that was very low. On top of that, what happened? The contract actually also abolished the catchment areas, and patients can come from anywhere and be able to actually receive treatment, while regardless of whether we have got a UDA or not. The other problem is we have diverse cultural populations, which actually some of them in particular have a lot of don't have actually a culture of visiting dentists on a regular basis. Consequently, the area has been in such a way has some difficulties in UDS in order to actually be able to provide comfortable supplies of dental care for the local patients, local people. What we are actually worried about now is under the new integrated system, we will like this new, particularly the budget, the fundamental budget, which has been constructed or determined in 2006, would probably be you make a basic the basis for the new commissioning. I think that's a major worry for us. Secondly, I think important is within our area there are a number of there's a number of dental practices who are actually very concerned with regards to the allocation of the budget in 2004 and 5, and they were saying to us something needs to be done, and the BDA has been informed of this, but so far nothing has actually been achieved. Quite happy to take questions on this.
Thank you, Tam. That's incredibly helpful. I think that there will be some questions in due course. Just before we come to Dr. Manbajood, who's joining us online, we're also joined in the chamber by Dr. Fourie, who's a dentist at the Clapton Dental Surgery. So, Dr. Fourie, if we can maybe move the camera over to Dr. Fourie, and as a Hackney dentist, if we could ask you to give your observations in the next 5 minutes or so.
Good evening, and thank you very much, Councillor O'Connell and Harris, for inviting me. I think I can just quickly explain my background. I've been a dentist in Hackney for the last 33 years. I think I've lost all my hair since I've arrived. And things has really changed quite a lot. And I think the difficulties that most of us have is the contract that's been, as explained by Andrew as well as by Tam, is that if you had a contract in 2006 that's maybe one surgery worth or a dentist worth, if there's any growth, the only way that you can do it is employ actually or see people privately, which actually for the local community is very difficult because there is a big increase in local community, but you don't really get the funding for that. So the only way that you can see them is actually privately. Now, working in Hackney, I've been an educational supervisor for health education in England for the last 25 years. So I've had a lot of young dentists come through my practice that normally stay and work there for 1 year. But currently we always keep those dentists, but we've got a big problem with retaining our staff. They have a tendency now to say, well, with the UDA system, and that you get paid maybe for 1 or 10 fillings the same historically, is that they would rather go and work privately because they can give more care for patients because they have more time, which is a difficulty for us. Now, just in general, I've been asked just to explain what difficulties we have and the ground as dentists. And I think most of them is basically patients that still don't turn up for appointments. We text them, we email them. And the problems that we have is if they don't turn up, that means we have to make up that missed time before the next financial year. Otherwise, we might get a clawback in money from health authorities. From the basis of dentists at work, COVID was very difficult for us. We had to buy, air purifiers with our own money to actually still work. With the cost of the energy that's going up, we find it more and more difficult to actually sustain, the patients that we have. I think Andrew have explained the UDA system. That's on a system where you get, for root canal treatment and fillings, you get 2 UDAs. There is a new incentive from government that will say, well, you can get now 7 UDAs. The problem is that means you still don't do a crown on a tooth. So in our audits that we've done, that means the new incentives they put in, it's not going to make really a difference for most of the dentists that work and try to follow the guidelines. There's also a perception of some patients that still, if they pay, even if they pay on a national health, that it's private work, and they don't understand the concept. They think everything on the national health is for free, and if you pay a little bit, they think it's actually private work. I think that's mainly the main things. And then there's a lot of waiting lists at the moment, and if people have to wait too long, there is bad reviews for practices, which is not always good. We try our best to help everyone as far as possible, but we've got long waiting lists. And especially if you take on new patients, where you have to do sometimes lots of fillings, it might take longer time than for your patients that you have on your books to keep them in appropriate time, to see them again. I hope that explained maybe the difficulties we have on ground level at the moment in Hackney.
No, it does. Thank you very much.
Thanks.
Can I now go to Dr. Manbajood, who's joining us online, and maybe again another local dentist, and also I think the treasurer of the local dentistry commission in East London. So over to you.
Hello, hi. My name is Reja Manbajood. I've been studying since 2003. I think most point is in Dr. Fourie and Dr. Andrew. But I would have 2-3 points. One is when the contract, our contract, 6, it really covered 50% of the population in UK, not 100%, because that never all population is registered with NHS dentistry. And this, I mean that if we want to see more patients or cover whole population, for example, in City Hackney, the amount of contract needs to be doubled, because this is not enough. This is just for 50% of the population in UK is covered by the current NHS contract. The second point is that regarding the contract itself, contract itself, as Dr. Fourie told, is not functioning. It didn't function before and is not functioning. I don't think so. With small changes, it's going to be functioned again. Is going to be a problem. I think that best things needs to be a real reform, real changes in the contract. In regard to the financial point of this contract, which come 2006, associate dentist was earning before 2006 around 80,000 K a year. No associate dentist earning 70,000 K after 16, 17 years, their incomes dropped. And that's why many dentists want to work privately. They don't want to join NHS because financially they are losing the money to work under NHS. I mean, mostly NHS associate dentists. And I think finally I need to also, I think my colleague mentioned, regarding our contract hasn't got uplift. I mean, that we haven't had the increase during these 16 years based off the real inflation. When inflation was 5%, our contract uplift was 2.5%. Even during the Mr. Cameron, if from 2010 2015, I think we had an uplift maybe around 1%, not more than that in 5 years. And the cost is gone up. Electricity cost, staff cost. We used to pay dental nurses, qualified dental nurses, 10, 11 pounds before COVID. Now we paying 14, 15 pounds, and they don't want to work. They want more. We understand them because the cost of living gone up. And if we were really is a good gesture from the government, we need at least 20% uplift of our contract this year, which is, I don't think so is going to be happen. If we want to recruit more dentists to NHS dentistry, encourage them to come to work, the practices to take a new patient and see more patient, we need a really uplift of our contract, at least 20%. That's all the point I could tell. Any questions? I am happy to.
That's again, that's very helpful with those different points and those different statistics as well. Can I now welcome Jeremey Wallman, who is the Head of Primary Care Commissioning for Dentistry, Pharmacy and Optometry for NHS England in London. As I understand it, Jeremey, the commissioning is shortly due to be devolved down to ICS level. But could you please give us your perspective, both in terms of, are there any opportunities with it being devolved down, or are we still stuck with the same contract, which might present some of the same problems? So yes, over to you. Thank you.
Yeah, thank you. And thanks for the opportunity to come and talk to you. I mean, I think I would be the first to say that all of the points that have been raised on this issue, I generally am in full agreement with. The issue around the contractors, and I suppose from a regional point of view, the easiest way I can paint it, we as a region play the cards that we're dealt, and that pertains to the contract that exists at the moment. You know, I've been a long advocate for contract reform. Without full contract reform, what we generally do as commissioners is we have to work around it to try and make the best of what is a pretty bad situation. It's a contract that doesn't work for patients, but if a contract's going to work for patients, it also needs to work for the guys who are delivering it. And you know, I think we've seen it. It was challenging before COVID. I think it's fair to say that it's even more challenging now. However, I think that the context for it is that the situation in London, although not great, actually compared to other regions, we fare better. Access to dentistry outside of London is not good at all. And I think part of the issue is that in London, obviously, given the proportion of providers that we have, maybe, and also the smaller geography we've got, it does make it slightly easier. That's not in any way to underplay the sort of significance of the situation we're facing. In terms of going forward, I think it's probably worth doing in the time that we've got. Yes, dentistry, optometry and pharmacy commissioning is being delegated out to the ICBs effective from the 1st of April next year. So the team that I currently oversee manage across London. We're London-wide, obviously, because we are employed by NHS England London region. And effectively, we will continue to be delivering as a London-wide team. However, we will be commissioned, we will be hosted, you'll be pleased to know, by North East London, ICB, which is, I think, a positive thing. from my perspective. It's from my perspective, there's a wider issue in terms of the need in North East London is greater in many of the boroughs than it is across the rest of London. But I think what it does is we are being hosted by an organisation that understands dental commissioning. There are a number of people within the ICB as it stands now who have previous experience of this. So we'll be heading in that direction from the 1st of April. With regard, does anything change? I'm not going to sugarcoat it. The contract as it stands at the moment is the contract. We, both as a region, but also as ICBs, have no power to change that. This is a contract that's enshrined in legislation. And ultimately would require an act of parliament for it to be changed. So what do we do? From my perspective, there's a little bit of looking at the probably drilling down a bit more than we've perhaps been able to do as a region, and look at the boroughs from a needs perspective. Does this new does the change mean that we're going to see loads more money? Probably not. But I think it's worth saying that actually whenever there's any change in terms of the structures associated with commissioning, it probably does provide a level of flexibility. And the thing for me is going to be that the cross-working with both local authorities, public health teams, means that we may well be able to do something a bit more positive than perhaps we've been able to do previously. I think what I would mention is obviously during the pandemic, the urgent care delivery across London, and obviously everyone's experiences are different to this, but the urgent care delivery across London, which continues to this day, is been held up as an exemplar across the country. So what I would say is if you have examples of anyone who are unable to access dental care, the urgent care delivery in London is via 111, but it goes through to a commissioned triage service. And we have 40 urgent dental care hubs operating across London, both in and out of hours. So no patient in pain should have to actually suffer for any length of time. Most patients will be seen within 24 hours if they are appropriate for that care. And this is a really, really important part. Access, routine access, and you know, I know Tam, I know Dewald, and I know Reja. We've worked together on and off for quite some time now. Access to routine care is difficult, and it's through no fault of the dentist. They are working extremely hard to work through a backlog of patients. So what we have as a backstop in London is urgent care delivery for those patients who either can't access general dental practice or choose not to. And I think it's really, really important, obviously, in a time when obviously many, many people are facing very difficult circumstances financially. Even NHS charges are prohibitive to a lot of people. So, you know, I've had someone, you know, sort of mention, oh, well, you know, band 2, which talks about, you know, root fillings and the like. Oh, well, it's only 50 quid. Well, 50 quid's a lot of money to someone who hasn't got 50 quid. So, and actually, if it's a choice between eating and having your teeth sorted out, well, you know what the answer is going to be. So I think there are many issues around the current contract that are very, very deep seated, and that it's a sense of frustration to me as a dental commissioner that we can't actually undo some of that, because actually there's a much, much wider issue here that needs to be resolved. But I think I'll probably leave it there, because obviously I could probably talk about this the whole evening, but just to open it up, but to say that there are things afoot in terms of what we're trying to do across London previously, but obviously probably going to be doing on a much more place-based position, and that we are always working to try and actually improve the position as best we can.
Thank you very much, Jeremy. That's very useful. Last two presenters are Siobhan and Richard from the ICS level and the Hackney level. I don't know if either of you, maybe, I'm not sure if both of you are intending on speaking or just one of you, but maybe can you just give us some flavour as to what you think the opportunities might be, just building on what Jeremy said about the point that it does get devolved down. Are you giving thought to how we can try and improve the situation, whether that be through certain enhancements, whether that be working through public health, I don't know, Siobhan, Richard, I don't know who was going to, Richard. Okay, Siobhan first, then over to Richard.
Yeah, I mean, if I talk more generally about the process, and then maybe Richard can talk a little bit about the City and Hackney specific opportunities potentially. I mean, Jeremey has set out that we are the sort of the ICB that will be hosting the dental, optom, and pharmacy team, commissioning team for London. So that means we will be needing to develop a set of working arrangements between both ourselves and with the regional office and with the other 4 ICBs, so that we have clear understandings about expectations, you know, how work will be delivered, how quality will be monitored, you know, how improvements might be owned at that ICB level, that we will be encouraging, I guess, the kind of approach that Jeremy's described to be something that gets implemented across all of London potentially. But there's quite a lot of detail in that planning and in that work. I mean, we're talking here about contracts that to the value of something like £870 million, you know, transferring across. So it's a big piece of work, and there's a lot of due diligence that needs to happen around that process. But it's potentially really great news from a North East London perspective, and the way Jeremey talked about the team, the primary care team within North East London has got a lot of experience of working in this domain already, and then obviously we'll be hosting the expertise of Jeremy's team, which will undoubtedly give us some degree of advantage in the process. So, you know, the opportunity to be able to be creative, and I guess, you know, to think about things as an ICS, and, you know, I guess looking to our political colleagues as well, potentially to think about, you know, the lobbying in the right places about where these problems need to be addressed, that are more systemic to the contract. That might be another opportunity we could think about. So I'll hand over to Richard now to talk about anything in specific from a City and Hackney perspective.
Thanks, Siobhan. I would add that we weren't just sort of gifted Jeremey and his team. We did make a very strong case to host him and his team, because we wanted that team in North East London, because we thought, you know, that does give us the home advantage, which I'm really hoping that it does. So, and I think this has been, you know, a great conversation. It's good to have all the issues aired to help me, Jeremey, Siobhan, and ICS colleagues to think about what all the issues are and start to come up with, ideas. I mean, I've been sort of inspired thinking about what I think the opportunities might be in City and Hackney. So, you know, utilising more of the sort of making every contact count approach. And that could be within primary care, it could be within community pharmacy, because we're getting community pharmacy as well. You know, working closely with the voluntary sector on this, thinking about what else we can do around the equalities aspect. We're already doing some quite exciting work around that in partnership with the East London Foundation Trust and the Change Please programme, who run a bus for the street homeless, and there's a dental suite on the first floor of that bus, and that's offering oral health promotion to the street homeless. So that's something that we could potentially build on for North East London. So early days, very early days. We haven't got it yet, but it's good to start the thinking now, I think. But there are clearly limitations, and we're not allowed to sort of write our own contract. So it's going to be, you know, developmental, but there are certainly opportunities there.
Thank you, Richard. There's a lot of ground there. I've sort of got lots of sort of questions swelling around my own head. Do any members want to start off, or let me get? In terms of, can I just get clarity? Maybe Siobhan, you could help. Is it the case that the actual commissioning? I appreciate the contract remains nationally, but is it the case that the actual commissioner will now then become the ICS or the board, or is it just that we're then hosting Jeremey and his team? So I'm just trying to get.
It will become a delegated function. It will, and we will have we will have a set of what we call MOUs, memorandums of understanding between North East London ICB and our London ICBs about how that delegation will work in practice. But the formal decision yet by NHSE as a board to delegate, that still hasn't actually happened formally yet. I think it's quite soon. But we have, in the same way that, if you remember, primary care being delegated locally, we have a very similar model. We have a London operating model for primary care in exactly the same way, where a lot of those functions have been delegated. And there are some things within primary care that are core contract that we don't negotiate or commission, but we maybe commission enhanced services on top. And there may well be also opportunities with these additional primary care services to think about what if there were investment opportunities in the way that Louise was talking earlier. There might be some things that we would want to commission as an enhanced service, but that's something that each ICB could make their own decision around, some of that potentially. But that's all quite further down the line. But Jeremy wants to come in, I think, in terms of
you've answered my question about enhanced services there. Thanks, Jeremy.
Yeah, I think just to sort of really build on what Siobhan's saying, I think the key thing is to understand is obviously the only difference obviously is in terms of the primary care level of delegation that went on, that was effectively one per ICB as it's panned out. So we are one team as it stands at the moment, and obviously we've reduced down over the years since we started as NHSE. So the disaggregation of the team is just not possible, because the team actually, if you broke it up, it numbers about 22 in whole time equivalent. It's very effective, and I'm not going to, but I think it's worth saying that that's the reason why it's effectively going to be delivering across London, albeit hosted by North East London, but we're going to be trying to, be effectively deliver a commissioning and contracting function across the ICBs. So it's just to understand that's the reason why each ICB doesn't have its own bespoke, or won't have its own bespoke, not to start with anyway, dental optom and commissioning function. However, the integration around that is that we start to then build in, as we work forward, we build in a level of resilience within each ICB, and actually utilize some of the skills from in our team to enhance those that exist within the ICBs now. So actually over time, we should be able to build up a bigger resource to actually work around this, because frankly, we're going to need it.
Thank you very much. Councillor Patrick was at hand.
Yes. Yeah, thank you. In the report, you talk about the new contract. I don't know, sorry, who wrote the report. I'm interested in the new contract and how it's going to work, and what you see as coming out of the contract in the prevention and work of with older people, with children, and also you talk about the Orthodox Jewish community, and that there's a problem that dental health is worse in that community. Is that the worst community for dental health? Do we know why? Were other communities surveyed? And I just wonder why we've gone to Kent. I mean, is there any particular reason that Kent NHS Trust, or whatever they're called, are leading, have been commissioned to do this work in Hackney?
So I think.
And is there anything more that the council and the ICB can do together to improve dental health?
So I think, Andrew, certainly the latter two of those points in terms of Kent and the focus on the Jewish community, you might be best placed to start off with.
Yes, so apologies, this isn't, despite being a dentist myself, this isn't in my portfolio, so I am speaking to somebody else's work here. But as far as I'm aware, that was some bespoke data. So we got that data specifically by working with that community, and it did highlight that compared to the rest of the borough, the rates of dental decay are worse. So working with our provider to allow them to subcontract to a specific organisation. I'm sorry, I'm not sure which organisation it is, but handing over the power to someone who actually understands that community better seemed like a very sensible way forwards. It's not too difficult to train people up to give the oral health intervention, to give the advice, but we do need people who understand what the issues are in that community. So hopefully that will get some better results, and we'll start to see some improvements. In terms of the provider, we recommissioned this service this year. They were our provider previously. It was very difficult for them to deliver during COVID. And I think they had to make a lot of changes as to the way that they were working, more advice based. But they won the bidding process. I'm not sure how much competition there was, whether there were many other providers who are available. But I think my understanding is that organisation does do a lot of training. They've got quite a good academic base, as well as a good track record of delivering services like that.
Thank you. Cllr Goldberg, I saw next. Sorry. So it may be because Andrew is covering for someone else's brief. It may be that we have to take that back. Yeah, I think that's I think the prevention work is specifically public health. So I think it may be in fairness to Andrew that we can look at that in terms of when we've got somebody who's actually whose brief it is. Cllr Goldberg.
Yeah, hi. Thanks everyone for coming this evening. It's quite clear is the current contract doesn't work and something has to be done. My question is more about, it's almost impossible to get an appointment these days. You call, I'm a father, you just don't get appointments. And if you're lucky enough to get an appointment and you take down your child, the patient care is absolutely, in most cases, absolutely awful. The attitude from the dentists towards the kids especially is just not great. Now that has nothing to do with the current contract. Speaking nice to people, giving decent patient care should be the basics. And if you don't want to deal with it, then perhaps don't be a dentist. I think the attitude issue, especially when it gets to the Jewish community, should be looked at, because getting an appointment is really a challenge. It's even a bigger challenge once you get there and you're on the receiving end of a dentist that is just not happy where he is for some reason, and vents it all out on the poor kids. I've been around there, done it many times, got no option, got to go private like most people in the Jewish community.
Thank you, Cllr Goldberg. Can I pick up 2 points there then? One in terms of access and one in terms of quality. Dr. Fourie, can I just bring you in terms of the access points? Because I think you referenced when you were giving your presentation about waiting lists. Is that for people who want to come to your practice to receive your NHS dentistry service, that you keep a waiting list for that? Or if you don't, have you got any way of monitoring sort of unmet need as to how many people would join up if they could?
I'll try to explain to you. So you've got a contract, and that means if you want to take on new patients, that means effectively you have to get someone that's already on your system off the list. So that person have to then be seen possibly privately if you fulfill your contract value, because you've got a specific contract. So to get someone new on, you need to potentially take someone off the list, because you take new people on. And so it's very difficult. It doesn't work in reality like that, but I just try to explain, if you've got a specific contract to get more people on, you can't increase it. The only way they can do it is privately. Also, if you take on new patients, that will take more time to see those patients. So if most people that struggle now to get actually on the dentist list is people that hasn't been historically seen. So they are the people that actually need treatment, but they don't get it. And because no dentist want to take them on, because it will take more time. So you can easily get a patient that needs 5 to 10 fillings or root filling. It will take you up to 3-4 hours, where normal checkup with a small filling will take you in half an hour, and dentists will get exactly the same money. So I think we've got a waiting list still from COVID. It goes over with that. The other problem that we have is retaining dentists. We've got difficulties retaining dentists to work on the national health. So where we in our practice had before 6 dentists that work on and off, we've got at the moment just 2 and another associate, and then we've got training dentists. So it's very difficult to keep on dentists as associates because they can earn more money in a private sector. What make it more difficult, we are on the border, Hackney and a city. So secondary care, private practices, they take on our staff. They can pay them more. So we're in a very difficult situation where we have to fight with secondary care, with private practice to retain our staff. So we'll train them. As soon as they finish their year, they will go off to areas in the same vicinity that have private practices because they will earn more. That's what's causing more of a backlog also with how we try to retain our staff, but also our patients. And that's why there's a backlog of patients can't see the dentist on the national health. I totally agree. Dentistry should be nice, and it's quite sad that you've got dentists that may be not treating people accordingly. So, but that should not happen. Thanks.
So just Dr. Fourie, so then I've got several people who want to come in, but can I just get clarity then? So when we're talking in terms of the 2006 contracts and also linking into the sort of the needs assessment that was done then, there are 2 distinct points. There's the point that whatever Hackney's need was then, essentially dentists Hackney can't take on more NHS patients than that, because essentially you've got to let someone go to take someone new on. And I think we see in the papers there's about 58,000 NHS. So there's that issue, and there's a second issue that I think someone on the call mentioned in terms of about the rates of pay continually not being uplifted with inflation, and then that's a real term decrease. Is that right? There are two sort of distinct areas.
There's 2 things, and the main thing is actually, we've got a contract of 12,000 UDAs. UDA stands for Unit of Dental Activity, which is the one you could say UDA if you do exam. And historically, if you do fillings, you get 2 points, and if you do laboratory work, you get 12 points. Once your allocation to that is fulfilled, then you can do the work, but you will not get paid, which make it very difficult. That's why dentists will then rather see people privately, because otherwise they will do work or they will not take people on to go over their limits. And that is the concern, that a lot of them have currently. Things has changed in Hackney where, 14, 16 years ago when you had 12,000 UDAs or units, things has changed where our practice has increased. We've got 2 more chairs since then. So the only way that you then can increase or see the patients is then to see them privately, which is a concern because, you still want to treat the local community and not everyone can pay privately. That is the big problem. There's no growth in the contract to increase, patients flow except privately.
Thank you. I've seen Jeremy's got his hand up, and that might be also to deal with Councillor Goldberg's second question. So if I bring Jeremy in now, I've got a number of hands that I'll bring in a second. Jeremy, also maybe could you just also deal with Councillor Goldberg's point in terms of quality, in terms of quality assurance as to what your observations are there. The sort of thing that we were also just talking about beforehand is if we just draw an analogy with sort of GPs. Sometimes there's a lot of support given, say, through a GP confederation to support practices, through training, through different cultural sensitivities, etc., etc. Might there also be scope to do that under a slightly different structure as well, to sort of try and drive up standards, and if there are quality differentials?
Yeah, I think it's quite an in-depth subject. I think part of the issue really relates to, I'll come on to the fundamental around this current contract, and Dr. Fourie and Reja and Tam. Contrary to popular belief, there is no such thing as formal registration within NHS dental practice, and there hasn't been since 2006. Now, that was probably something that was conveniently or just not mentioned when that contract was implemented by the politicians at the time, because that fundamentally changes everything. And as Dr. Fourie has turned around, you have a contract, as long as that dentist can deliver the contract that it has in front of it, there is no obligation to take on reams and reams of new patients. They're not obligated to do that, rightly or wrongly, but that is the reality. But patients don't understand that, because they assume that if you're with a practice that they're registered, understandably. But the obligation to a patient exists for the duration of a course of treatment, and that's it. And that has been the case since 2006. But again, a lot of this goes around communication. I think in terms of, I mean, there was obviously a very thorough training program for dentists. And in terms of the quality side of things, I think, you know, obviously in terms of how that's monitored, you know, obviously there are formal complaints made, and we do get complaints, then they're obviously looked into. We have a professional body of clinical advisors that will deal with that in terms of both professional standards and obviously in terms of just, you know, generally the way that patients are dealt with. And if that's legitimate, that's followed through with it. But quite a lot of it's obviously anecdotal or soft intelligence, which actually obviously is difficult to work with. So I think part of the issue is obviously you're not dealing with a level playing field in terms of how general practice and general dental practice are managed, but also funded. And obviously they are two very different disciplines. So in terms of going forward, I think anything's possible. And I think that anything that actually provides us with an opportunity to actually do things differently, then we've got to embrace that. But I think, as I said, we are working within the constraints of a national contract. So anything that we do, we have to work around that, because the contract we've got at the moment doesn't allow us to do as much as we want to. And I think just touching on the bit around prevention, and I'm sure my GDP colleagues on here, there is nothing in the contract that rewards prevention at all. And there really isn't. So again, whatever we do, and this is where I think the flexibilities are going to be really, really stark in terms of how we work with the local authorities and our public health teams to actually improve that, because that potential is there, but it won't be via this dental contract.
Thank you, Jeremy. I've got a number of people wanting to come in. Catherine from Healthwatch has had her hand up, so I'll bring Catherine in next. And then I've got three councillors, Cllr Adams, Baffour and Turbet-Delof to come in. So, Catherine.
Yes, thank you for the presentations. They've all been really interesting, and I've learned a lot. I would say that the feedback that we've been getting, and I did have a look at the issues that we've been getting feedback on over the last 18 months, are primarily around just access to practices, so people phoning around sort of 16 practices and being unable to register. The length of the waits that people are being asked to make as well in terms of accessing treatment as well. So that whole access issue is the #1 concern that we get lots of inquiries about. I would say though that in terms of when people do see dentists, most of the feedback we get is generally pretty positive. So yes, people sort of general feeling about quality and empathy was sort of 83% positive. So that's a sort of something, you know, to report back to dentists who are, I'm sure, struggling at times. I'm not entirely clear how these changes are going to help with access to dentists, and that seems to be the overriding issue for people. Or is it going to make no difference at all? Like, yeah, I'd like to sort of get some sort of idea of that.
I think the sad response we might be getting is because we're stuck with the contract, it's not going to make a difference to access, and I think that's what I'm understanding Jeremy to be saying.
I think initially, I think initially, I think that's a fair view, Catherine. I think from my point of view, it's like with anything, there's a level of the unknown going into this new environment in terms of us being sort of effectively delivering on behalf of the ICBs as opposed to NHS England. But I think probably what it does is it affords us a level of flexibility that perhaps we don't have at the moment in terms of looking in depth a little bit more drilling down a little bit more. And actually there will be flexibilities. There is a sizable budget associated with NHS dentistry, and it's just about examining what flexibility do we have to either rebadge some of that money, or actually to really focus on those areas of need and actually improve access. So whilst I would look at it initially to say, well, the contract is what it is at the moment and we don't have the power to change that, at the same time, it doesn't mean going forward that because we are working across we're working in a different sphere, that we don't have a bit more flexibility to improve things. And I would hope that would be the case.
And just before I bring in the other councillor, I see Siobhan's got a hand up. Siobhan?
Yeah, I just wanted to add that, I guess it's one way of looking at it, isn't it? Is to say, that it doesn't look like there could be much change. But I think if we think more about ways of working and how we do things and how we can get under the skin of stuff in a way that when a function is quite remote from us, from a delivery perspective, it's very difficult to do that. It's much more difficult to do that. And I think just having the team both closer, but also having that overarching, ambition to reduce inequalities and improve equity of access across a number of things, and how we work as a primary care function across a number of services, and how we work with our partners in public health is going to be absolutely critical. And how we just develop those opportunities and those things that we may well be able to improve oral health, but we'll only be able to do that by coming together really and doing things in a slightly different way.
Vaughan. I want to, Councillor Adams, I saw your hand next.
Thank you, Chair. My question is about the backlog of NHS patients not being seen, and the dentists doing a private work for them to be able to carry on doing NHS work. So how are they catching up with the backlogs? Are they actually dealing with the backlogs while they're doing a private work when they have a backlog? So it's just not very clear.
Could I maybe bring in maybe one of the dentists to talk about a backlog? So maybe Dr. Manbajood, because you maybe, so I mean, are you seeing sort of a backlog of patients, and how are you balancing that with the private work?
The NHS patient is NHS patient and private patient is private patient. When is the backlog? Many patients can't wait for a long period and they want to join and get the treatment privately. Of course, the people who could afford it. And I don't know, backlog would continue until I think some sort of balance be created, as Jeremy told, maybe in future. But I think that the most important point is that the contract which we have really is difficult to achieve it, because in this contract, telling that we need to provide comprehensive dental treatment for all patients. But the payment or structure of the contract, even the BDA mentioned, we can barely provide a core treatment base of this contract. Until that, the contract issue is not being solved. I don't think, and of course, if recruitment, a lot of dentists went back to after COVID and this Brexit to Europe, is a recruitment issue. They were working very low prices. They accept this NHS prices to work. But no, the dentists who qualified in UK, they don't want to work with the low prices, and they want a good payment. If they want to join NHS and to do the work, we need to give the good payment for the dentists who qualified in the UK. And the other country, they are not coming. If we want to bring back lockdown, we need to recruit a lot of dentists from the abroad, which I think they they trying to do from India. I think I heard to bring some dentists there, and there's a recruitment issue.
Can I just ask, just on this point, is the recruitment issue preventing you from taking on more NHS patients? So, e.g., if that wasn't such an issue,
Yes, yeah, of course. This is a recruitment issue, yes. Because 2011, when I was putting advertisement for a dentist, it was getting maybe in one day 50, 60 application for the position. No, it's not coming. Nobody applying for this position when I'm putting application, for the dental position. Nobody want to come and work under NHS.
Siobhan or Richard, I certainly know in Hackney previously, when there's been recruitment of GPs, as sort of an extra supplement's been sort of given in terms of as a sort of an extra encouragement factor. Again, could this be something sort of thinking laterally at the point things had evolved, it coming into whether that could possibly be considered? I know money's obviously tight and stretched across many areas, but I'm just trying to think about the way we support GPs in those sorts of situations.
Yeah, that's exactly I explained. We need at least 20% uplift of our contract, that we can pay a better UDA value, unit of activity, to the dentist, that they can consider to do, for example, some NHS work.
I guess I just think in broad terms, money is extremely tight, and we're going to be obviously going into and recruitment across a number of professions. Recruitment is, I think it's something like 120,000 nurses vacancies for nurses alone in London. Recruitment and staffing is a major problem at the moment across a number of functions in the NHS, and we've basically had a kind of permacrisis is like one of those terms that at the moment I think really is relevant. If you think about hospitals and how people feel like in the middle of July it was like the worst winter of all time. So it's very, very stretched, the system across the board, and I hear what colleagues are saying, but I think it's going to be very, very difficult to kind of justify one profession receiving a kind of that kind of bonus over another necessarily. Certainly not unless it's something universal, I think, as well, because then you're just propagating more of the inequity potentially.
No, I understand. Thank you.
Yeah.
I see Andrew's got his hand. I've got a few other councillors. I saw Cllr Turbet-Delof first, then I'll bring in Cllr Baffour. So Cllr Turbet-Delof.
Thank you, Chair. It seems a bit of a big topic to begin to approach and resolve quickly. It kind of feels as well that it needs a two-part session. So the limited time available that I have for intervention, I will focus on mental health especially under my role of mental health champion for Hackney. And I will also put a question to the panel on a possible feasible preventative proposal that I'd like to hear your thoughts on. Just so from the mental health point, I want to acknowledge that the severe impact lack of dentistry has on mental health on young people, on adults, and entire communities. It's quite painful to choose care over death, which is now a common practice because of the long waiting list. I know that myself, incurring in debt because there was just simply not access to care. I also, as I think Jeremey Wallman said, it also has a lot of impact on staff delivering the work, and I'm really pleased to hear that has been acknowledged here. Research also says that the staff in dentistry are really on a burnout, and they also are on a tight schedule because of these contracts that are not serving not the patients, not the people delivering it. So this is the last bit. Mouth Cancer Foundation tells us that every 3 hours, one person dies of mouth cancer. And I have learned through researching that dentists are often the first ones to notice symptoms through oral checkups. Yet Cancer Research UK says that there isn't or doesn't seem to be a national screening campaign. So the question is this: is it possible that we as a borough can introduce a local screening for mouth cancer screening as part of the patient checkups that is within these current contracts? Because I believe that this will drive and improve the relationship residents probably will have with their annual health checkups, which is not a high level of checkups that is taken, as we have heard, and the data provided, and potentially will not mean extra cost, but literally just making sure that this is something that happens on a regular basis. Thank you.
Could I maybe ask Tam Bekele just to answer in terms of the mouth cancer point from a dentist perspective? Is that something that you currently look for, or you think you would be equipped to be able to assess, possibly with further training or not?
Yeah, oral cancer incidence in East London is quite high. That's very true. But dentists, dentists do actually provide some checks while they're providing the treatment as a matter of course. But I agree that dental check, the oral cancer incidence in City and Hackney, Tower Hamlet and Newham is comparatively very high.
Dr. Fourie?
Yes, I just want to mention, it's very important, but with every checkup, there should be a hard tissue and soft tissue examination. So with every checkup, we do a oral screening for cancer, automatically should be done. With every checkup, it's always included, yeah.
Everyone use their microphone.
Sorry. Thank you. That's really reassuring. The reason why I asked this is because the data that I saw, I believe is in the dental, I don't want to make a mistake with what I'm quoting, but this is from the British medical sort of journals that I found, that it said that, yes, it is understood that this happens, that dentists should be doing this, but they're saying that a good third of dentists, dental clinics that might not be practicing this. So I think that's a really good point. Can Hackney have the assurance that this is happening on a regular basis? Because that will definitely be a preventative action that, you know, residents, and if residents know that when you go to dentist, this is happening, I think it will also improve the relationship that people have with their oral hygiene. Thank you.
Yes, we train dentists to actually do a full check. So that should include soft tissue, hard tissue, you know, automatically with all examinations.
And Dr. Manbajood, you've got your hand up there, so I'll bring you in now if I can.
Yes, this screening, cancer screening, is a part of dentist checkup, and every dentist know and must to do it. And also we have a very good referral pathway to refer to the hospital to this cancer's patient. But the problem at the moment, we are not doing a lot of routine checkup because we have concentrated on doing this backlog treatment and other things. That's why it could harm some patient to find their cancer in early stage.
Thank you. Just before I want the other part of Councillor Turbet-Delof's question in terms of the link to mental health. Siobhan, I mean, is that something that in terms of sort of the joint working and mental health strategies, again, I suppose that's possibly that can only improve with it being delegated and thinking laterally across different areas.
Yes, I would definitely see that's the kind of opportunity that we should be able to strengthen, really. I mean, I think the service at St Leonards, the Kent, I think, does provide some specialist services to people with kind of learning disabilities and some mental health issues. But I mean, I completely agree. I think, and it's a bit like Richard's point about the homeless earlier, you know, the people who, and how we can make sure that we can think about providing some of these services to people who are even in mental health hospitals and things. We just sometimes don't really think laterally, as you say, enough when bringing our services together in that integrated way, so that people's needs are met in a more holistic way. I think that's absolutely some of the opportunity that we should be looking at.
I saw a councillor before.
Yeah, thank you very much, Chair. I think my concern is like more to do with issues surrounding the contract and also the service delivery and the funding, which has been long-standing issue and has had so much of kind of demotivation within the structure, the system of operation, considering the backlogs and the maintaining good services and good hands and that kind of the areas. And I appreciate when Jeremey said there's something more to do. Just what I want to know from Jeremey is at what point the council comes in to ensure fair contract review.
Councillor, from Jeremey, in terms of what? Sorry, can you just repeat the last bit there in terms of the question?
Yeah, at what point, in terms of reviewing the contract, at what point the council comes in to ensure that the contract has been reviewed to ensure fair balance to the dentist and the NHS or whatever?
Jeremey?
Yeah, I mean, it's a perfectly reasonable question. I think that there is no answer to it at the moment. I think in terms of a new contract, I think, you know, we're a way off that at the moment. There are changes being made, which have been referred to earlier on. In terms of reviewing it, it's not something that's in our gift at the moment. You know, ultimately, this is something that's negotiated between previously, certainly the Department of Health and as was the BDA, the British Dental Association, who negotiated on behalf of the profession. You know, as I said, we have to work with whatever we've got at the moment and try and work. So I don't have an answer to it because there isn't one at the moment. I would like to see a reformed dental contract because I think that actually is in everybody's interests. But I think the only thing that actually is going to start to drive that, and hopefully, is concerted lobbying by the ICBs ultimately back up the food chain to actually try and get this change facilitated, because that's what's needed.
And the reading between the lines, is it the case that the government possibly doesn't want to redo the contracts in fears it will only go one way in terms of costs? In terms of the cost, I mean, is that the reality of the situation?
Yeah, I mean, I think we've got to be realistic about it. You know, and it's been touched on. In order for this to work, it needs to be seriously changed. The reform is one thing, but you know, in terms of the remuneration, yeah, I think it would be remiss of me to say that actually it's fine, because without a root and branch review of the contract and a change in terms of the way it's remunerated, you know, things won't improve. So I think that's absolutely right. And, you know, reading between the lines, given obviously all of the priorities that exist at the moment, you know, dental was on the table in terms of the various changes we've had in terms of Secretary of State. Whether it's going to be on the table after tomorrow remains to be seen. But we have to then try and persevere and actually just try and come up with, you know, it's incumbent upon us as the sort of deliverers of this to try and actually come up with something that works with or without a contract reform, because ultimately we've got to try and improve this for patients.
Thank you. Councillor Adebayo?
Thank you. I think Jeremey has answered some of my question, because my question is about how the new contract is likely to enhance the situation on the ground, because from what I've heard, it's like there is lottery being played in terms of residents accessing dental treatment.
Mm-hmm. Yeah, there is, you know, and it is a fundamental issue, and I think it goes right to the heart of what we've been talking about tonight. There's a big inequity. I think the only thing that I would say is that, as difficult as it may be in some parts of London to access dentistry, as I said, and again, it's all relative to the position that any community finds itself in. But the access to dentistry in London, actually, compared to other parts of the country, it's far worse outside of London. That doesn't, as I said, that doesn't mean for 1 minute that things are great here. but we are in actually a better position than most other regions. And I think part of that is, as I said, is around the geography, because if you go outside of London, actually accessing dentistry, people in some cases are having to drive 70, 80, 100 miles, whatever it is, partly maybe because they live in a rural community, but there just isn't an NHS practice for miles and miles around. So I think part of it is we have to get it into a little bit of perspective, but at the same time, it doesn't mean that we shouldn't be working on trying to improve the position as it currently stands in London.
Jeremy, I was welcome to hear about the 40 hubs in terms of urgent out of that. Is that across London? Is it?
Yeah. So yeah, it is. And just to give you context, we set those up in a direct response to the pandemic situation where dental practices were closed, and we were charged with setting up urgent dental care centres because, you know, with or without a pandemic, people were still getting toothache and were in pain. And so that means we've got 40 across London. There is a 24-hour, 7-day-a-week delivery from the triage service, so people can ring 111 at any time. And if they have a dental issue in London, and we are the only region in the country that has a full-blown dental triage service, in nowhere else outside of London has that delivery. But it means that people can be fast-tracked very quickly, and they can either be directed to an urgent dental care hub, and there's a collective opening for those centres, which is anything from 8 a.m. through to 1 a.m. in the morning. They're not all operating that, but that does avail. And people can either be directed to them immediately or actually can access them the following day. And we have that delivery, and we've maintained that delivery because without it, we would have serious issues in London in terms of people not being able to access dental care when they're in pain. So that is still in existence, and we plan to continue with it.
And is the pathway only through 111, or can a resident?
No, it is through 111. But I can guarantee you, if through 111, if you ring up, if you live in London, you ring 111, and it's a dental issue, it goes straight through to the dental triage service, and straight through.
I'll bring in Dr. Manbajood in a minute. I mean, just one observation. I mean, I've had casework about that in previously. I'm not. Just in terms of, I appreciate there's also the point about over-advertising a service.
It's fine.
But I think it's not completely understood that that's necessarily access route, but it's great that it's there.
Yeah, it is there, and as I said, it's a backstop for us, and you know, we would be sunk without it. And that was a purposeful move, certainly for my part as a commissioner for London, that we needed to have it. Because the demand was, you know, our triage service used to deal with probably about 120, 140 calls a day. Obviously, they were working on reduced. We are still experiencing in excess of about 12 to 1,300 calls per day into the triage service via the 111 urgent care delivery. So that gives you some idea about the requirement for it to still be delivered. And with that level of demand, we would be remiss to pull it.
Thank you. And we've got a few minutes left. Dr. Manbajood?
I need also mention one of my practices in Stoke Newington High Street, providing this urgent care. It's one of the hub. We start to have this urgent care hub since June 2020, almost 2 months after the coronavirus lockdown. And I think that all this credit we need to give to Jeremey, and it was really helpful for the patient. And without these hubs, I think we were worse situation than outside of the London at the moment. But we need to thank Jeremey with these hubs.
Thank you.
He saved London.
Good to hear. Thank you. Siobhan, one last very quick question. Dentistry appearing in the ICS strategic plan that Zena's currently working on. I don't think it was there in the last draft.
No, it's a good point. Definitely might give that. I will take that back. And I also wanted to just commend. Is it? I'm sure I couldn't quite catch the name of the councillor, but the point about mouth cancer and stuff, I thought there's really excellent things for us to think about. So thank you for those really helpful comments tonight.
No, thank you. I'm going to draw it to a close because we're at time. Thank you very much, everybody, for bringing this together. There's certainly a lot of things we can think about, and we note the political point as well in terms of lobbying. It may well be that maybe a year or so post the devolution, we can maybe revisit this item in terms of if there's any further thinking about things that can be done, and maybe just sort of trying to sort of hold the ICS to account as to what further thinking's been done on that and how things have progressed to take it forward. There's obviously a political point for us, and to the extent that we can provide any further thoughts or recommendations as well as it becomes evolved, we will do so. So with that, everybody, I'm going to thank everybody very much. Can I just before I formally close the meeting, the minutes are on the agenda. Can I take them as agreed, please? Thank you very much. The work programme for noting. I haven't been notified of any other business. So with that, I'll close the meeting. Thank you, everybody.
Thank you.
Thank you.